Hello, my name is Dr. Payal Kohli, and I'm a cardiologist who specializes in non-invasive and preventive cardiology. I graduated from Harvard Medical School, and I currently own and run a general cardiology practice in Denver, Colorado. In this video series, we're going to be tackling 5 common misconceptions around the use of coronary CT angiograms, or CCTAs, in the diagnosis of coronary artery disease for our patients. And we'll be debunking some myths. This is our 3rd video in our series. A misconception that I commonly hear from my colleagues is that coronary CTA doesn't impact cardiovascular outcomes. Let's take a minute to review the clinical data showing why this really isn't true. There are many studies that support the prognostic utility of coronary CTA, but I will review 2 of them with you today. The PROMISE trial randomized over 9,000 patients to anatomical testing using CT versus functional testing with traditional stress tests. A sub-study of the PROMISE trial showed us that coronary CTA offers better risk discrimination and prognostication compared to our traditional testing. This really improved our patient management. The study also showed that patients with normal coronary CTA results had a lower rate of cardiovascular events, so there was a high negative predictive value. For example, if you look at the lowest Kaplan-Meier curve for the CTA testing, you see that those patients that had a negative coronary CTA with no plaque had a 3-year event rate 60% lower than the 3-year event rate of a negative stress test. The Scott-Hart study was a game changer too. It was a robust randomized trial published in the New England Journal of Medicine in 2018, and it showed that patients randomized to a coronary CTA strategy had a 41% lower rate of cardiovascular death, or MI, at 5 years when compared to the standard of care, which relied on stress testing. This is quite the impact, and the reason why Scott-Hart was heavily referenced within the ACC/AHA updated chest pain guidelines, which gave CTA Class 1A recommendation. Now I'd like to take it just one step further. Ordering CCTA can not only improve patient outcomes, but by adding the physiology or the FFRCT to the diagnosis, you can also impact those patient outcomes. Let's quickly look at 2 more studies. The first is the Advanced DK Registry, which analyzed patients with coronary CTA and FFRCT and showed that the relative risk was 88% lower at 3 years for patients that had a normal versus an abnormal FFRCT. And the second study, which is a PRECISE study, which was a global randomized prospective trial that basically confirmed exactly what the chest pain clinical guidelines tell us to do. Patients with stable chest pain and suspected coronary artery disease were randomized to either traditional diagnostic testing pathway or to the coronary CTA first pathway plus the FFRCT analysis. When compared to the traditional pathway, which was functional testing, coronary CTA plus FFRCT resulted in a 70% reduction of all-cause mortality, non-fatal MI, and invasive coronary angiography in patients without obstructive CAD. By changing the test that you order, you can actually reduce major adverse cardiovascular events in your patients. I think that's just incredible, and this can have a profound impact for our patients that we manage every single day. In summary, coronary CTA absolutely impacts many cardiovascular outcomes. With coronary CTA, you get better risk prediction, better prognostic capabilities, and most importantly, you can reduce those major adverse cardiac events. Be on the lookout for other videos in our series debunking other misconceptions regarding the use of coronary CTA. After all, we went into medicine to do the best for our patients, and this means keeping up with the latest evidence and changing our behavior accordingly.